back to the chat show of the month. So this month we have the topic we have selected is CA cervix, and we have the best person, that is Dr. Neerja Bhatla, madam. Madam is the professor and head of the department AIIMS, New Delhi. So madam is here. I welcome madam to this chat show. So before madam, you have been working for the gynae oncology as well as especially cancer cervix for a long time. Madam, can you just start the discussion on carcinoma cervix? What we plan is that we have few case scenarios, and through the case scenarios we will be covering in the next 1 hour maximum points. And it's not possible to cover the whole cancer cervix and the pre-malignant lesions in 1 hour, we all know. But we will try our best to give you an overview to it so that you can go back and read. So most of the clinical points we will try to discuss. Okay. Before starting it, madam, welcome. Madam, what is the, according to you, what is the burden of this carcinoma cervix all over the world and especially in India? Because you are the person who has done maximum work on carcinoma cervix in India.
So thank you so much, Dr. Aswath, for this invitation to be here today, and congratulations on starting this beautiful initiative. I have to say, I am a great admirer of Dr. Aswath as a teacher. I think he has a wonderful approach which combines, as he already said, about knowledge as well as the exam orientation, both of which are extremely important for any student, because we cannot lose sight of the exam. That is our immediate goal. But for the long term, we need knowledge. We need a good foundation that we will be able to build upon. So congratulations, Dr. Aswath, and thank you, madam, for having me here. So talking about carcinoma cervix, you know, this is one of those cancers which is a very unfortunate situation that we see so many of because of its highly preventable nature. And yet it is such a major public health problem for us in India. So this is one cancer which every student, whether MBBS, whether MD, has to know about it. Any student does not know about this, it is a very serious mistake. So having said that, what is the importance? The importance is that there are still about 600,000 cases every year globally, and we are contributing from India about 1/5 of that burden, almost 120,000-130,000 cases. We don't really know the exact numbers because it is not a notifiable disease, but these numbers are generated from our registries with some degree of extrapolation for areas that are not suitably covered, some kind of formulas that are applied. So there is some discussion always about what is the true number, but it is the trend that is important, because these are the statistics compiled in a method called GloboCan, the Global Cancer Registry, which is done at the International Agency for Research on Cancer. Now, because this is a public health problem, because it is 85% of the cases in the low and middle income countries which have not made the systematic screening programs.
Okay, madam. See, can you, in the exams, they ask a simple question like, what is the commonest cancer in India? See, we have breast, and is it till now also in the, according to cancer registry, CA cervix is highest, or it has been overtaken by CA breast in India?
It is overtaken by breast. So if we talk about cancers in women, not our gynae cancers, cancers, cervix is the most common. In the women as such, in all the registries, almost except maybe in some rural, it is breast cancer which has become number one.
Oh, that is what I just wanted students, because it's a very common question the examiners ask the students.
And okay, as whenever we are screening for cervix, we must also examine the breast, because that is not a good thing that she gets screened for only one cancer.
That is what, madam, in your exam, when you are, even if you are getting a CA cervix, it is a must that you have to examine breast. That is also okay. Now we will go from scenario to scenario. So, and some questions which go through this. See, a 40-year-old lady, para 2, leaving 2, presented with a history of postcoital bleeding since 2 months. On examination, vital stable. Per abdomen, soft, no mass palpable. Per speculum, 2 into 2 necrotic mass in the anterior lip. And PVPR, that's the fungating friable mass arising with the anterior lip, bleeds on touch. Vaginal walls were free of the disease, and the right and left padameter was also free of the disease. This was what the picture. So I just wanted to start with, see, madam, what are the common symptoms by which the carcinoma cervix presents?
So the first thing we must understand for any cancer anywhere in the body is that in the early stages, all cancers are asymptomatic. They are silent. They usually manifest themselves when they grow to a size that they cause a pressure symptom, or they grow to a size that they destroy the normal functioning of that organ, and therefore the deficit is felt, or they cause a problem because they start getting friable and cause symptoms like bleeding and ulceration and all that. That is true for cancers anywhere. And so also in cervix, if it's an early cancer, it can be asymptomatic. There is the role of the screening to pick up the asymptomatic. Or there could be patients who present with these type of bleeding patterns, which could be postcoital bleeding, which could be postmenstrual bleeding, which could be intermenstrual bleeding, because there is a friable growth sitting there which can bleed on any raising of pressure, any straining, etc. Or because this is sitting in the vagina, which is full of all kinds of bacteria, it gets infected very easily, and they present with a persistent foul-smelling discharge. And these are the most common things in the early. Sometimes when they have gone for a checkup to the gynecologist looks at the cervix and says, this is an unhealthy cervix. Somehow they can make out that this is not how a normal should look, even a Paris or whatever. So that also sometimes we raise our index of suspicion and send directly to Kolpo. But other symptoms are usually symptoms of advanced disease like pelvic pain, like even back pain, like any symptoms pertaining to the urinary tract or to the rectum, or they are even fistulas in the later stages, a sciatic nerve pain because of involvement in that area.
The lateral pelvic wall.
Those are all the lateral pelvic wall. So those are the symptoms which pertain to advanced disease.
Okay, madam. The next is that, see, madam, tell some salient points in examination. You are going to, while examining a cervix, okay, imagine that such a case, we will come to the premalignal lesion afterwards. Imagine that such a case, there is a growth on the cervix, okay. So, how do you approach this? While clinical examination is very important, as we know. So, what is the approach to this patient?
So the first thing is that per speculum examination is a must, and I hope that everyone will make this as a habit for every woman coming to the clinic throughout life. That is very, very important. We don't necessarily feel all. But when we do a per speculum examination, we have to look for the cervix, the size, the shape, the color, the os, the squamocolumnar junction, is it seen or not seen? And in this case now where we have a tumor, so where is the tumor? Tumor could be a fungating type, tumor could be an ulcerative type, or tumor may be growing inside and causing a barrel shape of cervix. So we have to keep our eyes open. What type of tumor are we seeing? Then when we have seen the location, we have to see, is it confined completely to the cervix or is it extending to the vaginal walls? And if so, in anterior, posterior, lateral, wherever. Now, sometimes, particularly in the anterior tumors and in the barrel-shaped tumors, we should also pay attention to the length of the vagina, because a shortening of the vagina also suggests that somehow this is causing some involvement and causing some kind of a puckering situation. Anterior vagina gets involved faster. In posterior, there's the posterior fornix, which gives a little bit of safety margin before it reaches the rectum. So this is what we will see in the per speculum. So if it is a fungating lesion, is it bleeding on touch and all that we have seen. And then we will go into the PV examination. In PV examination, we should be commenting on the consistency of the cervix. And we know normal cervix is a firm cervix. If it is a hard and indurated, that is a suspicious cervix. Then we have to look again at this growth which we were feeling, and are we able to feel where is its margin, where is it extending till? Are the fornices normal? Are they shortened? What is the situation there? Is the cervix seeming mobile? Mobility of cervix is a very important thing to document. And then comes the involvement of the parametrium. Now, we can only palpate the fornix to some extent by the PV examination. And what is very, very important in the case of a cervical tumor is what we call the PVR, the bimanual pelvirectal examination. In this examination, our one index finger is in the vagina, our middle finger is in the rectum. We must use a good lubricant to put it in and tell the patient that I'm going in. Go in gradually, go in with the pulp of your finger, and then introduce the finger. And we palpate the parametrium between the two fingers. And that is how we know it is involved or not involved. If it is a smooth thickening, it may be inflammatory. So we need to see, is it just a very smooth thickening with some element of tenderness? We can give antibiotic, anti-inflammatory and repeat. And as we mentioned already, that there can be a lot of infection in these patients because of the nature of the location of the tumor in the vagina. And if it is a nodular thickening, that is definitely very suspicious. If we are feeling the growth just coming towards the rectum, we can also feel in this examination whether the mucosa is intact or whether the growth seems to have come into the rectum itself. So these are the important points that we have to mention in the PS, the PV and the PVR.
Yeah. And madam, see, you have seen now, you have examined, clinically you have just staged it, but you have to confirm the diagnosis. So when you have a growth or an ulcer, so is there any need for doing a pap smear or anything else, or you directly go and take a biopsy?
Yes, directly a biopsy. Once there is a growth, there is no role of pap smear. In fact, you will be surprised that even in growth, you may get a negative because the cells may be only the necrotic which we have taken and the pap smear.
That is what, how do you take a biopsy? That is what they ask you.
Again, which we take, and for a biopsy, where already a growth is there, the normal punch biopsy forceps works very well. It's that Gaylord punch biopsy forceps, which is typically in every OPD. For a biopsy, which we have to take where there is a pre-invasive disease, a better forceps is the Thrissur forceps, which is very fine and very sharp. And it is very quick to take the biopsy because when we have this friable type of growth, we don't need much force even. So we have to locate the right place. So taking it from necrotic area again will not get you the answer. At the same time, if we go too much peripheral, sometimes we're seeing a frank growth, the report will come as carcinoma in C2, CI3. So ideally, we should have two biopsies. One is from the growth itself, and one is more peripheral, nearer to the margin, so that the tissues will not be necrotic.
Okay, but there is a usual question.
And you can put them in the same pot. You don't have to put in separate.
Put in different. Another question which is asked is that, okay, you are taking biopsies. Very common question when examiners ask. It starts bleeding. Okay, see, it can any potential to bleed. So you take biopsy immediately. You are taken in the OP and it's pouring out. What are the ways you can manage this?
Yeah, some amount of bleeding is to be expected and it will settle on its own. But if there is bleeding which is significant, the easiest and best thing to do is to pack the vagina. Pack the vagina, keep the roller gauze ready and leave it there for an hour or so, and then you can remove it and send the patient home because it will settle with the pressure. And other things are there which can be used, of course, but typically they are not required in this type of a scenario.
Okay. Madam, you have taken the biopsy, you have sent it. But along with, when you are having an ulcer, do you want to take any endocervical, or you just have to take from that growth itself? Anything else?
Yeah, when you are taking it with a frank growth, you don't need to take any endocervical curating or anything like that. If the growth was not visible, then that's a different matter.
That's it. Is there any role for this when you are having some doubt with the parametrium is inflammatory or nodular, some doubts in the initial? Is there any role for examination under anesthesia? That means
examination under anesthesia kind of become a defunct procedure. because in many settings, an examination under anesthesia will be more expensive for the patient than doing even an MRI, because it will be an OT procedure. So it is different situation used to be in the medical colleges where patient is not paying anything. Even there is so much pressure on the lists. So this was, and it is still an option depending on your scenario. Sometime you may be in such a setting where there is no feasibility of good imaging, you may do it. But otherwise, really, you get so good imaging now with the MRI particularly. If not available, you can do CT scan. And even a good ultrasound by a good qualified radiologist, a transvaginal and even transrectal ultrasounds can be done to assess all these things very, very well. So if you don't have it, yes, there may be a possibility.
Madam, see, at your center, ideal, we will talk about the ideal because examiners will ask an ideal situation. So such a case previously, see, in my PG days, years back, I'm telling 20 years back, this was enough to stage the disease. Okay. You have taken biopsy, you have sent it, and the biopsy has come as squamous cell carcinoma. Biopsy has come with a result. But what further investigations is a must according to you? What imaging modality is a must, and what informations you want to get from biopsy? See, just not
and
just.
One thing I want to mention here, Dr. Aswath, the differential diagnosis in our country still in such a patient must remain of tuberculosis. Never presume it is cancer. Biopsy is must for treatment. We have seen exactly like this with tuberculosis. And if you do a colpo, you see a lot of endocervical component, very proliferative typically. The report comes as tuberculosis, and after ATT, it melts away and becomes like a normal cervix.
Hello, madam. As you told tuberculosis, can you tell some salient feature? Because we in Kerala, in South, we don't see much tuberculosis cervix. But as you have seen, students from all over the India is there.
But once in a while, we do get it. Once in a while, we do.
Okay, so you have taken
exactly similar story. It will be.
So what investigation? See, you are just superficially told specifically what will you advise MRI, CT, you have different things.
MRI is the best method for imaging the soft tissues. So to see the extent of the size of the tumor, the extent of the stromal involvement, looking at the parametrium, and you will also be able to see the nodes. So that will be the best method for looking at the pelvis. The parametrial involvement, however, is the least accurate of all by any imaging method. So we always have to keep our clinical sense uppermost and take the decision accordingly. So once we have this, the next step will rightly be to go for an MRI to assess the extent of the lesion.
Okay. Madam, now we have reached a staging system. So there was in 2008, there was a staging system which was modified to 2018, and some further modifications have come. So you will be the ideal person to tell what were the modifications in the time. According to the time it was progressing, what are the modifications and why these modifications were made?
So this is the staging system modification came because, as we have discussed, there has been so much improvement in the imaging. And that has helped us to understand, because previously what happened was that suppose we see a patient, we label her as a 1B, we take her up for a radical hysterectomy. Intraoperatively, we find the lymph node is involved and it is positive too. But we will just continue with the surgery. We will complete it and we will say that the staging has not changed. We will just note this. We know that the prognosis has changed completely. We know that this patient is not going to do as well as any of her contemporary who did not have the lymph node involvement, but the staging would not change. The staging was clinical. And for a reason, because it is mostly in the LMICs, there are some areas, particularly in Africa and other parts of Asia also, which are very disadvantaged, and patients don't get to have any kind of, even pathologists are not there, radiologists are not there, very difficult. So it was clinical. But what was happening now was that it was a lot of divide with so much of improvement in imaging, not only the MRI, but the PET CT, the PET MRIs which are coming. So many things are happening. Then there was the advance in MIS, and what people were doing was what they called the surgical staging. If they see any lymph node positive, especially in the para-aortic region, then they would go in laparoscopically to pick up that node and to find out is it positive or not, and to base their radiation and the extended field radiation based on that. You know, extended field radiation is a big decision, because when you go up the para-aortic, then there is a lot of side effects because of the radiation to the vertebral column and the bowel and so many things. So in many places, the radiation oncologist will not give the radiation if there is no documentation. So now there was a big gulf between the developed and the developing that was coming, and it was necessary to bridge that. And that has been bridged by this via media, that you use whichever system you can, and over time we will see the reports and we will see if it is further to be. So what were the main differences? One, of course, was that in the stage 1A, the lateral dimension was removed and only the depth of invasion was considered. Very importantly, in stage 1B, there was divided into 3 substages with an additional cutoff at 2 centimeters. This cutoff came based on the information from radical trachelectomy cases, how much the prognosis deteriorated when the tumor is more than 2 centimeters. Suddenly, there is a drop in the survival and an increase in the recurrence rate. So it was based on that data. All staging changes are informed by data, and all students should make a vow that whatever discipline they go, they will systematically record their data and publish it, because that is what the evidence-based medicine is built on, and what we in India are a little bit poor in doing. So then in stage 2, there was not really much difference. And in stage 3, the biggest difference was that there was a creation of a stage 3C for any lymph node positive. If it is pelvic node, it is C1. If it is para-aortic node, it becomes 3C2. And you could document this by radiology or by pathology. So radiology, we have discussed how you will see the advanced lymph node, the enlarged lymph node, but it doesn't mean that it is necessarily a positive one till you have a FNAC or you have done a surgical sampling. So you have to take a call, and unfortunately in many of these patients, HIV, TB are common occurrences, so they could only be infective. So the surgeon, the clinician takes the call, decides, do I think it's positive? I send her to radiation, or do I think it is negative and I will take her for surgery? And then at surgery further, it will be decided. So now in this system, the pathology rules. Whatever is a pathological diagnosis, that will get priority. So you thought that the tumor was only 3.8 centimeter, you operated, but the pathologist says it was 4.2. The stage will change. You thought it is a 1B2, but pathologist has said largest dimension is 4.2. The stage will become 1B3. And similarly, the lymph node, you thought it is not it is enlarged, but it is not significant. Pathologist said no, it is. It will change. So the pathologist rules, there is no doubt, but between clinician and radiologist, there is not necessary that radiology rules. So as I said, the radiology may say parametrum is involved. You are convinced on your examination it is not. You can choose to go ahead and not take the radiology opinion. So I hope I'm making myself clear in that.
Very good, madam. Very clear, madam. Very clear. So this is what they are asked usually. So some changes from this 2018.
So what happened was that after we published this, which was done in collaboration with all the major societies, AJCC, UICC, staging systems and all, but there were some more differences that came out afterwards. One was that we had said that we will not have micrometastasis to be counted as metastasis, only the macrometastasis, which means more than 2 millimeters. But they said, no, we would like the micrometastasis also to keep it at par with some other pathological classifications. Secondly, this more than equal to. So it was decided that we will keep it at 1B3, for example, more than 4, 1B2 more than 2, so that the 2 comes into the previous 1B1 takes up to 2, 1B2 takes up to 4, and more than 4. So that was published in the corrigendum later on.
So students, this is what the latest changes are. This equal to has been removed. Okay, and the micrometastasis.
I have made 2 slides to just share at some point.
At the end, I will
give them these links which they can read it up.
Okay, I will. After this, I will give you.
So don't worry about that.
Okay, so we have come to the staging system. So this is what Madam told. All these things are. All these things, Madam, do you agree with this? If the margins of the corn biopsies are positive for invasive cancer, the patient is allocated to stage 1B1.
Yeah, this often excites a lot of comment. But the general thing was that if you look at the size of the tumor, that it would have been, the amount of tissue that there would have been and the total size and the total volume. But I think it will have to be on an individual basis that you have to decide. Because in general, they will go to stage 1B1 because of the virtue of the kind of lesion that you have. But there may be some very rare cases of very superficially spreading ones, which could be an exception.
Okay, Madam. So this was what we told. These are some other things, Madam, points like...
yes, so LVSI does not change the stage, but should be recorded. And in a stage 1A1, if there is LVSI, it would tilt the balance towards needing to do a lymphadenectomy, for example, which may not be required. Now, extension to the uterine corpus and ovarian involvement does not change the stage. The main thing is there are not enough cases of these being reported for us to be able to determine the prognostic significance, in the survival curves to see the differences coming. But it's very interesting that in one of the, many retrospective analysis were done after the new staging came. Many people looked at their data with this staging in mind and came out with what their impressions. And what was seen in one by Kailash Narayan from Melbourne, he showed that very often these patients who have uterine corpus and ovarian involvement also have lymph node involvement. So the stage is actually already changing.
Okay, Madam. Then we will go for the management part. So, Madam, you can take one by one and then short comment you can give. This just I put a slide for you to start your discussion. So
we are in. This is one situation where we have to accept that radiotherapy has a part in all stages, whereas surgeons have a part in only some. So there's no doubt about this matter here. So early stage cervix can be treated equally well by surgery or by radiotherapy. But in the locally advanced cases and even in the distant, we'll talk about the locally advanced, it is radiation and usually the concurrent chemoradiation, which is the recommended situation.
Okay, now, Madam, we'll come to initially the stage 1A1, like that we will go initial stages. And
broadly, 1A1, let us talk about first. So as I mentioned in 1A1, we can actually have a situation where even a conization, which has been done adequately, margins are clear, there is no LVSI, that itself may suffice. Or in some sort of a situation where the woman is elderly, completed family, she may like to go for one TLH and that will be the end of that matter. But if it is a situation, and we have this here already, right? Now, if they are desiring, if they have the LVSI, then we have to decide about whether we need to take it further in terms of removing some part of the parametria or not, and whether we want to consider it for a radical trachelectomy or not. But in 1A2, basically, again, you have to see very nice chart you have brought, Dr. Aswath, which shows that if they are desiring fertility, the conization with the close follow-up or the radical trachelectomy can be considered. And the older people, completed family, can consider to go for the type 2 hysterectomy. The pelvic lymphadenectomy is important in all the patients.
All the patients, okay. Now we go, so that was 1A1 and 1A2. Okay, what you have told. So if we go to 1B1,
1B1, 1B2 and 2A1, this is the category of patients who require, actually speaking, the type 3 hysterectomy as a rule, as a ballpark rule. And there are some patients who are definitely benefited. We mentioned how they could go for radiation or for saying some patients are benefited by surgery, and that includes the young women, where we are mostly able to save the ovarian function. In CA cervix, ovarian involvement is usually less than 1% of cases.
Madam, you tell about ovarian function saving means what you mean?
I'll tell you. So that is the case for surgery. And then if we have a situation where patient may have a TO mass or fibroids or prolapse, then again, those patients are better off getting surgery. And if there are patients with comorbidities that preclude them to have the prolonged surgery and all, then they may be better choice to go for radiotherapy. So like that, we have to decide what is broadly speaking better. But 1B1, I mentioned already that it was the trachelectomy data that brought about this cutoff. And if they desire fertility, then that is the way to go, a radical trachelectomy with a pelvic lymph node dissection. And the older women will go to the type 3. In all cases, the PLND will be done. And in the ones which are 1B2 and 2A1, they can go again for the type 3 hysterectomies and the PLND. The radical trachelectomy, either they will have the pelvic lymph node at the same sitting with a frozen section, or they will have it in 2 sittings. So you do it one day, you send it to normal processing, and then 1 week later, you do the radical trachelectomy. So a laparoscopic lymphadenectomy, and 1 week later, the radical trachelectomy. Both these methods are being practiced by different settings.
Madam, just one word. This is not used, I know, nowadays. These classification of type 1, type 2, type 3 classification. Would you prefer to have this classification or this classification?
So yes, so the better one nowadays is considered to be the Kernow-Morrow, and I think the students should go with this one. So basically, it broadly corresponds to the Piver Rutledge. And I think for the sake of the MD, we can just broadly put it as the corresponding. So there are some finer differences in between the two. So type A is the one which is like our type 1 with an extrafacial hysterectomy and a less than 10 mm. That slide is gone. Maybe they can just take a picture of it and see.
Okay.
Type B is the transection at the level of the ureter, and type C is where you mobilize completely so that you can get till the lateral pelvic wall. And here the C1, C2 they should know. The C1 is the one with the nerve preservation. C2 is without the nerve preservation. These are the nerves which go to the bladder and the bowel and are very important for their function. The type D is seldom, if ever, really done.
Madam, they ask usually, what is this extrafacial and intrafacial hysterectomy? That is what, see, these are all common. What do you mean by an extrafacial hysterectomy?
It's actually, this is just the facial layer that surrounds the cervix. And typically when you are doing a hysterectomy, usually for benign disease, we cut the fascia and we push the whole thing down and we completely bare the cervix. But in the extrafacial, we retain that facial envelope and we do a sharp dissection to cut off the bladder and leave that facial envelope which contains the lymphatics with the cervix. So endometrium also that is recommended.
This is there in NCCN guidelines. Everybody can go back and see. It's a comparison between all the whatever you have told. The whole comparison is given as a chart. Very wonderful chart. Students, please go back. Due to lack of time, we are not going into details of this. Now, the other question which is very commonly asked now, what is the route you prefer in CA cervix? So almost all the, I have been as an examiner for a large, when it comes immediately they will ask the student that which route you will prefer. So it's a very clear controversy. So madam, can you highlight that controversy?
So actually, you know, there are a few trials which PGs must read in their course. I like to talk about even the studies by Freda on the Rh negative and how he did the studies that led to the 3-day later anti-D. And there are some other trials like for giving folate for prevention of neural tube defects. These are, you know, very landmark trials which must be read. And the LAC trial is now one of these landmark trials because it was started by a group who never anticipated that this result will come. They were devastated with their own results because they were doing so much minimally invasive on almost daycare basis, like countries like Brazil, high load and sending away. They got into a problem with this, how to manage their caseload and their beds. So this was the study where they were randomized to getting open versus minimally invasive. And to their utter surprise, they found that the disease recurrence rates were much higher in the minimally invasive group. The disease-free survival rates were worse, and the progression-free survival rates were worse. And moreover, the sites of recurrence also were different. In the women with the open approach, it was more at the vault. With the minimally invasive, they were even within the abdomen at distant sites. And so they had to conclude really that the minimally invasive route was not suitable for cervical cancer. Now, because you can understand, people were really upset about it, including patient surgeons. Everybody loves MIS. But why should this happen? And especially because in CA endometrium, equal oncological outcomes have been proved, and it is quite the standard of care. So it was postulated that perhaps the fact of that tumor sitting right there in the vagina and the high pressures of the pneumoperitoneum cause somehow these cells, which are to be shed and to be blown into the cavity as well. And so it was decided that it was enough evidence to not continue on a routine basis with MIS, but it should be done only in study protocols, and various studies were developed and are still many ongoing, which includes that you take the vaginal suture, dissect the vaginal cuff, take the suture so that that tumor is not exposed, that you do a conization immediately prior and first remove the tumor bulk and then do the rest of the radical hysterectomy. So various things are being tried in that respect to see how we can do a minimally invasive more safely. But at the present time, the evidence is in favor that it is not a suitable one. And even these trials are focusing for the time being on tumors that are less than 2 centimeters in size, the smaller tumors, the 1B1 tumors.
So students, the madam has told that when you are asked an exam, you have to tell open surgery, preferably, and you can tell there is about this trial and all those things. But for the time being, please answer as open surgery preferable. Okay. So, madam, next. This is another thing. What is the role in, see, we all know the role in vulva, we all know the role in endometrium. What is your view about sentinel lymph node mapping in cervical cancer?
So it's something that is not yet the standard of care, but I do believe that it will be, because the concept is definitely there, the same as it is for CA vulva and the CA endometrium. But as of now, it is not the standard of care. The concept, of course, is that every cancer has a primary node into which the tumor first drains before it goes elsewhere. If you can identify that node, pick it up and test it, and if it is negative, then the rest of it will also be fine. And if it is not, then you have to give the adjuvant treatment. So there are a few things that are important in this. One is that you should have the resources to do the sentinel node mapping, because it depends whether you are going to take a methylene blue dye, which is not of the best. It has a very hit and run and disappears. Or you are going to take the lymphoscintigraphy, which is not everywhere. Or you are going to take the ICG, the indocyanine green, which has now become common with the robotic surgery concept. It is available in laparoscopy also. It is now available in handed also. But it requires that extra input of the infrastructure is to be there, first of all. The pathologist has to be with you in this, because ultra staging is required. It is not the routine sectioning. Very fine sections, 4 millimeters, have to be cut and examined. So it is a concept of a team that has to be developed to do this and you have to have your own learning curve, of course. So for some time you do sentinel and you do the complete and you match your results.
Madam, just one view about which are the candidates that you select for radical trachelectomy. Madam, do you or do you believe in radical trachelectomy, or you do cone and do lymph node dissection? What is your concept about?
We do believe in the radical trachelectomy, but I have to say that even now, our cases of cervical cancer who have not completed their family are very few. Very few indeed who still need to retain their future fertility. Most cases of cancer, even today in India, are after the age of 30 years. And as we know, most women in the group that is more susceptible for this cancer is the lower strata in general, the less affording, multiparous, poor hygiene, poor nutrition, more infections. So those people are all the ones who are mostly still completing their family by the time they come. We have had 1 or 2 patients who have completed family, but they think they might get married again. So we still want to keep the cervix and they are there. So we don't know about the fertility, how it came out. So the first thing is they should want to keep their fertility. The second thing is that they should have a tumor which is less than 2 centimeters in size. So a stage 1A1, of course, is fine with LVSI. Without, we will do just the simple cone we discussed. 1A2, 1B1 is fine. The lesion size more than 2 centimeters is not an absolute contraindication, but it is something where people have recommended to do an abdominal radical trachelectomy rather than a vaginal trachelectomy, because you remove the parametrium better by the abdominal route. Then, of course, we have to say no evidence of metastasis. I already mentioned that you need to know about the node. So either you are doing a frozen section there and then, or you are doing it before and doing it after 1 week. And many places, even Netherlands and all, where they don't have good frozen section, they do this after 1 week type of a scenario. And you have to leave the cancer-free margin. So you can't take something which is going into the cervical canal if you cannot take off 2 centimeters, and then you still want to leave behind adequate length and put the cerclage so that they will not have an abortion. So in any procedure that we do after conization, whether it is a hysterectomy or whether it is a trachelectomy, we like to give 4 to 6 weeks gap to allow the inflammation to settle. But one thing I will say is that for a radical hysterectomy, we don't worry so much usually, because we are going to go fairly lateral and that inflammation usually does not matter so much. But in trachelectomy, because we have to stitch the uterus with the vagina, it still matters, and we like to give that gap. So basically, yes, these are the criteria.
These are, Madam, see, you have done radical hysterectomy and pelvic lymph node dissection. Okay. What is the role of para-aortic lymph node dissection in CS cervix?
So the para-aortic, first of all, we would have got the imaging to see that there is no evidence of para-aortic lymph node enlargement. And when we open the abdomen also, the first thing that we should do is to look and do the exploration and to feel that there are no enlarged nodes. If there is an enlarged node, the first thing to do is to take it out and send it for the frozen section. If on frozen section, the pelvic or the para-aortic lymph nodes are positive, then the patient is to be closed and sent for radiation. This is very important, because if we do the radical hysterectomy or a radical trachelectomy, of course, will be incomplete in such a setting where it is now a stage 3C type of a situation. But even in a radical hysterectomy, when we do a hysterectomy and we leave very short vagina, then we change the dynamics of the vaginal brachytherapy. Because when we put the tandem into the uterus, then we get the isodose curves in a particular way inside the pelvis. But if you have already removed at least 3 centimeters, 2 centimeters of vagina, that tandem cannot even go in fully to give adequate radiation to point A and point B. So it's very important that we recognize the patient's benefit. Second point is the dual treatment has a lot more morbidity. So the morbidity of surgery, followed that by the radiotherapy, these patients have many sufferings. This was an important reason to classify it, because if you give the dual therapy, the survival curve will not change. You have done the surgery which was inadequate, or you have done a simple hysterectomy and it is found to be a cancer cervix. That also happens time to time. But you have given radiation. Survival curve will not show her suffering. It will not show how much morbidity she had.
Madam, few questions they ask is that in your exam, see, today for the students, today we will be discussing only carcinoma cervix. Premalignant lesion, there is no time. So, few more, and we will stop at premalignant in any other time. When madam gets time, we will be discussing. So, one thing is that a patient with prolapse, with these are all questions, madam, as a going as an examiner, which I got from my co-examiners. A prolapse with CS cervix is there. Prolapse with carcinoma cervix. So early stage. So what is your approach of surgery? That is what they ask. Is there any role for vaginal radical hysterectomy?
Yes, the vaginal radical hysterectomy can be done, but you see, it does require a certain expertise in vaginal surgery. So this was the Shorta's approach, which SCHAUTA, Shorta, which was very famous. And there was an Indian surgeon, Dr. Subodh Mitro, who was very, very famous surgeon for this technique. And then his son-in-law after him, Dr. N.N. Roy Chaudhary. So these people in Bengal have done a lot of vaginal radical trachelectomy. The drawback of the vaginal radical trachelectomy is that for the lymph nodes, you still need the abdominal, either 2 extra peritoneal incisions Dr. Mitra used to do, or you will go by the midline and do the 2. So that is still required. So yes, if the capability is there and the expertise is there, but we have to be safe and we have to know how to dissect the ureter. So it's quite all right to even do it from above, but you have to make sure that you secure the element of managing the prolapse. Even abdominally you are doing it, it's all right, but that repair to secure the vault is very important.
Madam, just tell something about ovarian conservation. See, you were told that ovaries are usually not involved, we all know. So during surgery or what you do, because to keep the ovary where you keep, or in which all cases you will conserve the ovaries?
So usually once the patient is more than 45 years old, we are a little more liberal about sacrificing ovaries in the CA cervix patients, but definitely not anybody under that age. Secondly, if the patient has an adenocarcinoma, then we do not like to conserve the ovary. So in these patients, we will do the complete hysterectomy, including oophorectomy, but in the younger patient, we will definitely conserve the ovaries. And if there is any doubt that they may be requiring radiation later, then it is a good idea to do the transposition. Transposition means we take it high up into the gutters, into the paracolic gutters, so that when the radiation is given, the ovary will not be harmed by that.
Okay. Madam, just one or two things on an advanced stage. We are going to the next. See, there is a special group actually, which you saw that more than 2 centimeter, more than 4 centimeter actually, in 1B3 as well as 2A2. Okay. Anything to the students that this should be managed specially, or
yes, is CCRT, and CCRT means that during the radiation therapy, every week, those 5-6 weeks, they will get the weekly chemotherapy. Usual drug of choice is cisplatin, and if it is not suitable for cisplatin for any reason, contraindicated, then 5FU. And with this, the radiation, external radiation is given the 5 days a week. And then after that, they receive the brachytherapy for the vagina. That is very, very important. Without that, the radiation is not complete. Regarding the role of NACT, there's an excellent trial from Tata by Dr. Sudeep Gupta and Dr. Amita Maheshwari, which showed that NACT means that we have a bulky growth, we give chemotherapy to shrink it down, and then we give the radiation, do the surgery. So this can be reserved for that setting where radiation is not available, because our results of this excellent Indian trial have shown that concurrent chemoradiation results are better than NACT followed by surgery. So this should be reserved for a setting where radiation is not available, but it is a second best.
Okay, so neoadjuvant chemotherapy. So then you come to the locally advanced. We will go fast. Locally advanced. So 1B3 to 2A, B and 2B and then 4A. 2A has gone to other side. 4A. So these cases is a concurrent chemoradiation. So usual one question asked for the students is that why do you add chemotherapy to radiotherapy? Radiotherapy was being followed up for years. Now, what is your and what is name? Which in few words, can you explain what are the common things that you should know about radiotherapy and chemotherapy?
So, adding the weekly chemotherapy, it is a radiation sensitizing mechanism, and it gives a far better result to the in terms of the survival rates. So, it is a very important thing that we have switched to. Of course, if we look at here, it can be. All these things you can read.
Okay, so this is just the things which why concurrent chemotherapy has been added to radiotherapy. So there are one is radiosensitizer, other is the concurrent when you give distant metastasis, micrometastasis can be followed up, and organ preserving intent. That is what the high dose cannot be given. Now, before coming to the a patient, madam, imagine a patient, many times this happens, in a periphery surgery has been done. As you told, uterus is taken out and the pathologist has reported as CSR. Okay. Patient has been, as you are an onco surgeon, patient has been referred to you. Okay. So what either you will go for surgery or you will go for radiotherapy? This is a question which is asked in your practical exam for students.
If she had a simple hysterectomy.
Simple hysterectomy. See, usually the surgeon never thought that it was a CS cervix, okay, or would not have done. Many times what happens is that many times CS cervix hysterectomies are done by surgeons also. I'm not blaming anybody. General surgeons do hysterectomy. And these type of cases come to once they understand that it is a CS cervix from the specimen, they send to us. So in the exams, they are asked the question is that the simple hysterectomy was done by you and it comes as CS cervix. What is the next step? What do you do?
So then the best thing to do is to send them for the post-operative radiotherapy. And the results of this post-operative radiotherapy are not as good as the results of getting a CCRT up front. But it is better than doing leaving them, of course. And second option would only be to do a completion of the surgery by doing a parametrectomy, and people have described that, but more often that is done if by chance at the time of surgery you get to know that you did a simple hysterectomy, and if the competence is there to do the radical hysterectomy at that same sitting, the radical trachelectomy, the radical parametrectomy and removal of the vagina can be done. But to do it afterwards in a patient who's already had the hysterectomy and a lot of, fibrosis and all that has happened, there are safety issues also concerning the, how the fibrosis and all is there. So generally speaking, we would just send them to post-operative radiation.
Madam, last 2 questions. How do you follow up a case? That means you have done a radical hysterectomy or you have given radiotherapy, whatever be the treatment given. How do you follow up all these patients?
So usually we have been following them with pap smears on a 3-monthly basis initially, and then 6 monthly till 3 monthly, 4 monthly till 2 years, and then 6 monthly. There are many people who argue that this is not required. PAP is a screening device; it's not for follow-up. But just as we were about to abandon it, we picked up 2 patients just by doing that. So, theoretically, you can wait. You can wait till you actually see some abnormality with your eye. But we feel better just seeing that we have found some changes. One very important point, Dr. Aswath, that I want to make is that we must consider giving hormone replacement to those women who receive radiation at a very young age, because this is not a hormone-sensitive tumor. And if these patients can be put on hormone replacement, it makes immense difference to their quality of life.
Okay. Madam.
So I just want you to take a picture of this, the students, and they can get this. Can you see the... yes, I think they can see, this...
they can see International Journal of OBGYN 2019. They can see.
This was the first one. And then the corrigendum, which has come, it has come in the same year in the next issues, 129 to 135, it is saying here. This is something is, take the DOI number. Take this DOI number. I'm not sure about this. Take this DOI number. This is 12749 and 12969. And you will get it from this. So this one tells you the final staging. And even in this one, when you take it out now and you click on the updates button, it will take you to the corrigend.
And the last point, madam, we can mention, and CS cervix and pregnancy. Yeah, it's the last point.
Yes, a very important point. So if they are pregnant and if they are in their first trimester only, then it will be better to consider aborting the patient and going for the appropriate treatment. But if they are reaching to nearing term, then we can tide it over, give them the antenatal steroids and deliver them around 34 weeks. And if they are in the in-between trimester, then we have to see what is the patient's desire for having this pregnancy and what is her stage. If it's a really very early tumor and the patient is very keen to have this pregnancy, then we can consider giving chemotherapy during the pregnancy in second trimester. It is okay. And then we can take her for the complete surgery. Of course, since we have to also explain to her that we are not going to remove the ovaries, so she does have the option of later on going with the surrogate, but we know how much confusion all that is in right now. So these are the three options for the 3 trimesters. And sometimes people actually prefer to do this radical hysterectomy with the cesarean section, because the planes are actually very, very well formed at the time of pregnancy. If you go in the wrong plane, there's a lot more bleeding. But if you go in the right plane, it is a much easier dissection.
Thank you so much, madam, for your time, valuable time which you have given. I know that you are busy after this, you have meetings.
Thank you so much. I've enjoyed the evening, and thanks to the students for being interactive and putting questions right from the start.
1 or 2 questions are there, maybe there.
Yes, one of them said, why can't we give HPV vaccine beyond 26? But you know, that all depends. The licensing depends upon the data which has been given. And it is most effective when it is given under 15, really. But now what is going to happen with the new SAGE recommendations, they are recommending a single dose under 15 and 2 doses up to age 20. So certainly older women can take, there is no harm in taking, but it will be less beneficial and they must have the screening. It is not a replacement for screening.
And one more thing, madam, if this students always ask about this nanovalent vaccine. See, what it is really popular, or we are still going with the quadrivalent and bivalent vaccine?
So nonavalent, of course, covers for more types, but it is quite expensive. So it is really speaking dependent on the pocket of the person who is it is out of pocket expense. So if they can afford it, it's very good. But the bivalent is presently not in the market. So bivalent hopefully will come back next year. They will again start producing. They've gone to shingles with those machines and adjuvants presently. Bivalent has shown excellent results in UK with their 4 years review, excellent and quick reductions in CA cervix and CIN. Our Indian vaccine, which is coming, is going to be quadrivalent. The Serum Institute, so Gardasil, Serum Institute vaccine will both be quadrivalent. In India, the HPV 16-18 is about 84%. It is much more than the global average of 70%. So I think even the quadrivalent for us is really pretty good.
And anyway, students asked about this. One question more for the practical purpose. Madam, nowadays we say HPV testing is, that was what a question asked by an examiner. HPV, is it enough? Why you want to do pap smear? That was asked to a student. So student get totally confused. So these type of questions comes only why, when you told about the importance of HPV testing, then the examiner asked, why then what is the use of pap smear? Why you are doing pap smear? That was the question. So madam,
yes, so that was the concept of co-testing initially, to do both HPV and pap. And if you have doubts about the validity of your HPV testing, with many people just use some homegrown PCRs and all that. So you may not want to rely on it, then you can still do co-testing, but otherwise it is now an era for starting with HPV testing. And only when it is positive, then you decide how you want to triage, by genotyping, by PAP, by VIA, or by colposcopy. All the 4 methods of triage are valid.
And one more last question. Another question which is now commonly asked is about BIA and Willy. BIA and Willy. Last question. Madam, BIA and Willy, what is the importance now? The present situation it should be the first test before pap smear, or it should be done only in places where you don't have pap smear facilities?
Yeah, and places we don't have pap smear facility include our medical colleges, where there are limited number of bottles which are available depending on the capability of the lab. So what we say is that don't let any woman go away who was an eligible candidate. So we even at AIIMS, we are presently doing PAP and HPV and BIA, but we make sure we do something for every patient. So Willy is not really in the program for 2 reasons. And the main reason is the Lugol's iodine is expensive. And the second thing is that to keep its supply chain going is more difficult. But acetic acid, you can give the glacial and the health workers can reconstitute it themselves at their end. So VIA is the one which is in the national programs as a routine, and the Lugol iodine part is usually reserved for the colposcopic examination.
So VIA positive means that is a patient which you send for pap smear and further.
Which, yes, you can then either do a direct colposcopy, or you can do a PAP or HIV or an HPV, depending upon whatever is available to you.
Anyway, it's a big topic. We will have a discussion separately on other. Anyway, just came about vaccine, so I asked 2-3 questions.
Sure.
Thank you once again, madam. It was a nice evening, and the students would have definitely benefited. And most of the students are going for exam next week, practical exam. So CS Cervix, I am sure that they would have got most of the questions from the authority in India. So thank you, madam, and thank you to be with me for the. Thank you so much.
Thank you so much. Have a lovely evening. Good night.
Thank you. Thank you. Good night.